Jeff, it's so nice to have you with us. Uh, I know as a graduate student, you were always interested in psychotherapy, and you even had a chance of having a class with the late, great Arnold Lazarus. Can you
Yeah,
take us back to those days and remember your
sure.
excitement?
Well, I would say that I was interested in psychology from a very early age, like probably in childhood. But
Oh.
um, like in childhood, I was always like the person who would listen to everyone else's, not just problems, or just talk to everybody, particularly people I was close to. So I was like sort of like a I don't know, born to listen to problems or absorb what people are thinking about. And I think that's just a natural part of me. And I think for many therapists, it's a good um, it's a good aspect of temperament to have already. So for example, when we're looking to choose therapists for training, I look for people who have this like a natural I don't want to use the word talent, but let's just say a natural interest or uh, comfort in understanding people, asking people about themselves, and have a genuine
Yeah.
interest and ability to do that. So I would say it start. So we're gonna start with me way before
Graduate, yeah.
Lazarus. Then in high school, I decided to start collecting psychological tests.
Mm.
So I started, it was on some kind of charity thing where we collected newspapers and then you gave them to charity. But the thing is, in one of the people's baskets was a test catalog, a psychological test catalog.
Uh-huh.
So I wrote to them and made up a name of who I was, and which wasn't too great. But in fact, they started sending me tests. I gave my friends the tests and would keep records of what they scored on different personality dimensions.
Wow, so
So, yeah,
already.
yeah, this was at 16 years old,
Ah,
probably.
great.
Then, uh, then in college, I continued being interested in psychological testing, and particularly personality, and happened to have a roommate. I went to Yale as an undergraduate. I don't think it was a coincidence, but my roommate was probably the only other person that I knew at that age who was also interested in psychological tests,
Uh-huh.
and he's become actually a well-known psychologist, Bob Sternberg.
Okay.
So, but we both continued our interest in that, and I worked for educational testing service for one summer over the course of of college.
Uh-huh.
So there was that leading up to it. But now while I'm in college, so of course I'm interested in psychology and want to take psychology courses. And one of the years I'm there, I think it was my sophomore year, they have a guest lecturer, a guest faculty member
Uh-huh.
who just there temporarily for the year, and it happened to be Arnold Lazarus, who at that point I had no idea who he was, but I knew that I wanted to learn every approach there was, even then, to both personality, but more particularly to psychotherapy.
Mhm.
So, in a way, I guess I'd say he was my first formal exposure to psychotherapy in an academic setting.
Mhm.
And he was a very, very inspiring lecturer. I mean, the
Very
most
charismatic, yeah.
very charismatic, extremely, exactly. And he would play, like audio tapes of him with clients, and
Uh-huh.
you know, and it was exciting, and it also had, of course, a theory behind what
Yeah.
he was doing, which I liked. I don't like techniques without theories.
But this
So,
was before his multimodal days, right? More the behavior therapy.
right, well, I'd say yes, but I think it was in part of the
The
developing of it.
transition.
Right, only because it was not at all. I knew Wolpe's model,
Uh-huh.
so I knew it wasn't pure Wolpe. He was doing some other things in addition to it that I wasn't sure where they came from, but I didn't. I knew they were not
So you
just
already noticed he was a traitor to the cause.
right. Yes, exactly. That didn't cause me to lose interest in Wolpe's work, but
Uh-huh.
it did lead me to be extremely interested in psychotherapy. So I would say it was a major, major turning point in that it took something that was a real interest just from early in life and made it into a more definite career choice. I
Uh-huh.
guess I'd
Uh-huh.
say I really decided from that point on, and also decided that I wanted to take a route of therapy more similar to his than to
Mhm.
psychoanalysis, which unfortunately at that time I hated, really hated it. I would read it and think it was ridiculously, it was convoluted. It didn't have a lot. Was not logical. So I
Mhm.
got very frustrated with it. Although later I came back to parts of it, but early on I really couldn't stand psychoanalysis and would avoid anything that was psychoanalysis.
So-
So, and that continued until many, many years later. So, um, so I guess at that point, I sort of decided that I was probably going to do something in psychology
mhm.
and go to graduate school. And then I had my idea then was I would be a psychotherapist,
Yeah.
basically a psychologist. I didn't think of psychiatry because I was not good at memorizing, and I didn't like to wake up in the middle of the night. So I knew that I was probably not going to do well in medical school, and I could never get through a residency where I had to sleep late and be on call. So
Yeah.
that wasn't even an option.
That's self-understanding. It's good.
Well, then I took a year off in between college and graduate school and tried to decide where I wanted to go. And what I decided was I wanted to find where the top people were doing interesting types of psychotherapy in any field, any area of psychotherapy, and see where they actually were and go and learn it from them. It was always my idea that the best way to learn a therapy, and maybe it was because of the course with Lazarus, was to go to the person who
Yeah.
was
To the
developing.
source. Yeah.
Go to the source, exactly. So the trouble is the source is not, can be in many different cities. It so happened that Wolpe was in Philadelphia at the time.
Yeah.
Mnuchin for family therapy was in psychotherapy.
Yeah.
Beck, who I was knew about, but not much at
Mhm.
that time,
Mhm.
was also in Philadelphia.
Yeah.
So I made a decision to go to the University of Pennsylvania,
Yeah.
primarily because there were a number of psychotherapists who had like summer workshops or training programs you could take in addition to what I was doing in graduate. Because I knew that graduate programs don't really teach psychotherapy, but I wanted to learn psychotherapy anyway, so I had to do it. I knew I'd have to do it outside of the actual graduate
And you were
training.
able to go to Wolpe Center, correct?
Right. So
That's
I spent a summer. I went to their summer training program. This was very early. Well, I can say very early, but I mean nowadays it would be considered very early
sure.
because there were very few there. But all the main people in behavior therapy were either faculty or would be coming all the
Yeah.
time as guest
Like
lecturers.
Edna
So I got
Fo.
it.
Yeah.
Edna, by the way, was in Philadelphia also at that time.
Great.
So there
The
was
Mecca.
Edna. Exactly. So it was like I really got exposure to all of these people, and many of them, I don't know, many of them probably people wouldn't recognize anymore because it's been so long ago.
Uh,
But it was a chance to get to know Wolpe, which was interesting, and his family. I
uh,
was also always interested in the personality of the person who developed therapies, not just in the therapy,
yeah, yeah.
and interested to know to what extent was their model coming out of them, and to what
Uh-huh.
extent was it something they were deriving through some academic or theoretical or empirical way, as opposed to something coming from their own nature or their own personality.
This might bring us later. I don't want to get us
Hmm.
off track. It might bring us later to something because I know even from the 1990 book that you have. I actually have it right here.
Oh, wow.
That you already quoted Fyodor Millen, and there's that great book by Fyodor that it's Masters of Mind, I think, in which he's
Yeah,
also like doing comments on the personality of the people.
exactly.
Uh huh.
Exactly. And I was always very interested in that. So personality,
Uh-huh.
even though the models I was studying were not about personality, I was always interested in personality, not to say disorders, but just personality
Yeah.
in general,
Sure.
more than I was in like what used to be Axis 1
Sure.
disorders.
Yeah.
Even though the models were all doing Axis 1, I didn't mind that much. But anyway,
So how
so
did?
I
Yeah.
go ahead, no, go ahead, yeah,
I think I'm gonna make the bridge like you were just about to do, which is so
sure,
you're in the Wolpe Center and you're in Philadelphia. How do you remember the experience of reading Cognitive Therapy and the Emotional Disorders by Beck
right.
for the first time?
Right. Well, that actually was going to be next because, well, in between, by the way, I did get a training from Mnuchin in family therapy, which is
Okay.
very fascinating, but I didn't want to really work with families. So anyway, so then what happened was so at this point, I'm in graduate school and I've already taken Wolpe's course, although I still going to weekly seminars, but still. And I happened to be in the bookstore at the University of Pennsylvania and looking at I don't know, whether it was the psychology section or looking at other psychology courses and psychiatry courses that might have interesting books to read.
Sure.
And there I happened to see Beck's book, which was Cognitive Therapy and Emotional Disorders.
Uh-huh.
So I purchased it. I had known about Beck, but had never read anything. And I would say that was another transformative experience because there I found a model that came closest to what at that particular time fit me personally.
Yeah.
And I could relate to it in a way that I couldn't to Wolpe's work, although I liked Wolpe's work, but I couldn't connect to it. But I felt like he writes incredibly well. It's extremely well laid out model. It looks inside the mind, not just at behaviors. So I really was very affected by that.
Looks like you're pretty
And then
excited.
yeah, exactly. And I decided I wanted to do my dissertation based on that. So I call Beck's Center, which at that time had like 6 people in it.
Yeah.
And no, I'm sorry, I'm wrong. So what happened was then I was teaching a master's level course while I was in graduate school to master's students.
And you introduced his book into your class.
Right.
Yeah,
And I introduced his book into the class. And then someone who's now a good friend, but she was working with Beck, happened to go to the bookstore and she was looking at the books in the psychology, and she saw his book ordered for a course, which was extremely rare at that time because nobody really knew much about who he was.
Sure.
And here was a course at Penn using his work. So she told Beck about it, I guess, and then he called me and asked would I come and have a meeting with him.
That's the first time you meet.
Yeah. This was the first time I met, right? So I came in, we had a meeting. I talked about the dissertation I was thinking about. He asked how I happened to see the book and how I liked it. And at the end of our talking, he offers me a position. He says, when you're done with graduate school, and first of all, he agreed to be in my dissertation committee. And second, he wanted me to come and work with him after.
How happy were you?
Yeah, I was extremely happy because here I didn't even have to apply or go through a process. And, it was like a perfect position, but I never realized at the time the impact it would have on me and my whole career forever. I mean, it's still the major turning point in my career.
And as a parenthesis, I know that your dissertation, I think, was on cognitive therapy for loneliness.
Right, exactly.
What drew you to that?
Well, loneliness had always been an issue for me, I'd say all my life. Feeling maybe different from other people in ways that I couldn't actually define what it was, but yet I always would feel somewhat on the outside. And I thought, well, here was an opportunity to take this therapy that I was interested in and my interest in loneliness and put them together. And that's how I did it. It wasn't because I thought loneliness was a specifically good fit for cognitive therapy. It was just because I took 2 of my interests and put them together.
Again, basically. The personality of the person pops up.
Exactly.
I always found it interesting that you did this topic of loneliness, considering that you later developed what I think is an extremely humane model. So it's very interesting.
Well, and it continues to be an interest. A lot of the attachment theory I got interested in came out of the interest in loneliness.
So then you do the postdoctorate at Beck's and you train with him. Most people are familiar with the cognitive model, but I'd be interesting for you to talk a little bit about what you learned from Beck as a person and as a therapist, the practical side.
Yes. Well, actually, I often tell people who ask me that I think it's a shame that the textbook on cognitive therapy didn't reflect better what Beck actually did as a therapist, because he's a very, very intelligent, sensitive, and skilled therapist, but without all the structure that you associate with the model.
In a good
So
way. Yeah.
in a good way. So he would be like a great, even though he wasn't that old then, but he looked old because he had gray hair even when he was younger. So he always came across sort of like a grandfather. He was extremely easygoing. I often say he was like Columbo, like he would act like he didn't know very much. It's why. Like, well, why do you think you're depressed? Your life doesn't seem that bad. Why do you think it is? And the person would say, they'd say, well, I just broke up with my husband. Oh, that's terrible, terrible. What happened? How did that, so it was like you could see the patient didn't feel that they were being like interrogated or a formal interview.
Yeah.
It was like he was talking to them, but in his talking, he was leading them to see a different perspective, but he blended it so smoothly and there was no structure. So it was not at all obvious what he's doing. And yet by the end of the session, because he has a strategy in mind, and you can see, once you know the model, you can see the strategy, but the patient would never see it because it's done through this very, very gentle, gradual questioning that leads the patient to see, have you ever thought about this? Or couldn't you think of it this way? Or something like that. And so it was amazing. And I began to, as I always have done, actually I didn't mention, by the way, I also was very interested in Ellis before and had gotten training from Ellis. So here was something that tremendous contrast in style to Ellis, who I thought was very interesting, but not a very good style. I actually tried using it with patients. It was terrible. But anyway, so here was a style that I could actually mimic it almost with my own personality, but using almost trying to imitate the style and translate it into me, because I could see how good it was. And I think what I take away from Beck in watching him, sitting in with him on sessions, or sometimes through a mirror, was not the model as we see it in the book.
Boxes.
What's the handbook of whatever it's called? The main book on cognitive therapy. It was the next book, a handbook of the main cognitive therapy book. But if you go back to cognitive therapy and emotional disorders, that is his model. That's how he operates. And through that and watching him, I really learned, how cognitive therapy could be done by someone who was really masterful. And I can't understate how intelligent he is, how brilliant he is. So, and not only is he a wonderful therapist, but he's a brilliant person, which continues to be true in every area that I work with him on. So I think a lot of people, I guess it's not shocking, but on the other hand, people might have an idea of what he's like as a therapist. It's very different from what he's actually like as a therapist.
It's interesting that interpersonal skill side wasn't so much explored in the early books. It's a shame.
Exactly. Right. And in fact, because other people did most of the writing, they recognized that to make it short, to make it structured and relatively easy to learn, they could put a structure around it that even someone less skilled could still be able to learn it and do it, but not with the finesse that Beck did.
I can imagine it made you question how much of the model was effective because of the techniques and how much because of this interpersonal skills.
Right. And actually what it made me do was that's true, but also I realized I knew I could, by watching the session and then later rating tapes of therapists in different parts of the country for outcome studies, that it was clear that someone where their style was off or their interpersonals were bad, the model wouldn't work either. So that's at that point I was developing that cognitive therapy rating scale to rate therapists. And I added in sections about the qualities of the therapist to be sure that wasn't omitted, because I realized by then that you could be doing every technique correctly, following the protocol, and still get terrible results. So
it's interesting that you mentioned Alice, because he was for me very important, and I've always wondered, because we know about all of these studies over the time about the importance of empathy and interpersonal skills, etc. And I'm always surprised how was Ella's effective, even though I totally believe that he could be effective. It doesn't fit with this general idea we have of interpersonal skills in some way.
Exactly.
Yeah.
Well, I think what it is, my own theory is he was only effective with people who live in New York. it's an exact, it's an
It's a
exaggeration. But my
cluster.
point is, if you live in New York, there are a lot of very intellectual, sort of very rationally oriented and smart people
uh,
in New York, in Manhattan, who were perfect fits for this model because
okay.
they weren't very they'd cut off their emotions as I
Uh-huh.
now look at it,
Uh-huh.
and they were in a very logical, rational world
Sure. Uh-huh.
and his internal world, and that's how the model worked. So when he'd interact with patients like that,
Uh-huh.
he did extremely well. And I would just say it's an example of having to find the perfect fit for
Yeah.
someone who didn't care about the interpersonal components, but would could learn through a rational process
Sure. Sure.
without the emotional part.
I'm
So
sorry for putting us a little bit off track.
no, I'm always interested actually in that part of it. Anything about the emotional versus the rational is of
Yeah.
interest
Well, I'm
because
sure
that's
we'll talk a
a
little
lot.
bit about that. Well, when you were in Beck Center, you were treating or seeing basically pure Axis 1 patients like depression,
See, I
anxiety.
don't believe there are very many pure Axis 1 patients.
Yeah,
They were
yeah.
supposed to be pure Axis 1 patients.
Uh-huh.
But in reality, what we learned was the number of Axis 1 patients who don't have personality issues
It's
is
very low.
very small,
It's very interesting.
particularly, yeah, that's my opinion.
Uh-huh.
So certainly there is a subset like that where maybe you can think some specific trigger problem happened in their lives. They were very healthy before, then all of a sudden some tragedy happens and
Yeah.
then they get depressed.
Uh-huh.
Of course, that there were some patients like that, but most of the patients had had issues in their lives before, and this was just another episode of depression.
It's
So,
it's
yeah,
great you're getting into that. I've always been questioning about this, and I even the Richard Westward, I think was his name.
yeah, sure, yeah,
He had such a great sentence, which was therapists had. We lived in a world with therapists with an Axis 1 mind in an Axis 2 world.
yes, that's exactly what I think. And in fact, now in DSM-5 they don't separate them.
Yeah,
There aren't two axes anymore.
yeah,
So, which was a good decision. But when I taught schema therapy, when I was introducing schema therapy, although we always want to know what the axis 1 disorder was, I'd always make it clear that it's the rare patient where you can work on axis 1 without working on
yeah,
schemas and personality
yeah.
dimensions because they intersected. you know
But then, having said that, how satisfied were you with the model then? If most of the people coming in with supposedly Axis 1 disorders, but even now you're saying that even those people had characterological issues.
Right. Well, the thing is that some people, even if they have characterological issues, many people can still use the strategies and get better from this episode.
Uh-huh.
The problem is it doesn't necessarily keep them from having another episode.
Yeah.
But more importantly, it doesn't necessarily make their life happy.
Yeah.
And this is something I learned from Beck actually through a separate way, is that being the absence of depression is not the same as being happy in your life.
Sure.
And what I always say to people, and I once said to ask Beck, I was asking him, this is when I was at his institute, and I was saying, why is it that when you develop the Beck inventory, there aren't items for every item? Why aren't there the positive ones? Like, I feel good, I feel great.
Uh-huh.
He says, well, we actually did that, but they came out as two different dimensions. The negative dimension of the negative was not on a continuum with the positive side, which makes it clear that being happy is not the opposite of being depressed.
Great.
Being non-depressed is the opposite of being depressed.
Great.
So it's important to realize that I was not satisfied having a patient go out, end therapy, have their depression gone. I mean, that was an accomplishment. I thought that was worthwhile, and I still do. But they still often were very unhappy in their lives.
Uh-huh.
They had major life problems, but they were no longer clinically depressed. So to
So
me,
you still felt that even in the clinic.
absolutely.
Uh-huh.
Yeah. And then when I went to private practice, where the patients weren't screened at all in a private practice, the way they were, because they were screened for
Yeah.
having major depression. They couldn't screen out every personality disorder. But when we did for depression, in a private practice, you have many more people who are subclinically depressed. So they have depression, but it's more characterological, like dysthymic disorder.
Yeah.
And many, many more of the patients were like that. And they would only have a minimal response to cognitive therapy. And that's what I think was more of the transition when I moved from a population that was primarily, which was, they were strongly depressed, to ones where they were more like a typical private practice situation, just like the normal patient population, where a percentage are clinically depressed, but a much larger number have depression, but not enough to be clinical.
Yeah. So, and
And
I guess this is at the time of the private practice, or when you go to private practice, is when you start hearing that often quoted phrase like, "Yeah, I can get the rationale intellectually, but I still
right,
feel the same."
exactly. I think that's what I put in that book you had, 1990, was
Uh-huh.
that's what I kept hearing from patients. And of course, it only would come up with what I now call schemas, because they wouldn't say that around like just everyday situations, trying to show them where they were not looking at it properly. But it might be something about self-esteem, and I'd say, well, as you can see, like, all the evidence doesn't justify your feeling that you're a totally worthless person. And they'd say, well, like, that makes sense objectively, but I still feel like I'm totally
Yeah,
worthless.
yeah.
And no matter what I did that was anywhere cognitive or behavioral,
Uh-huh.
it wouldn't change that.
And
And
imagine
that's
it
when
was a pretty frustrating time as a therapist, no?
right, it was frustrating but for me, frustrating is challenging because
Okay,
it's
good.
boring. See, it's boring if you do the same thing over and over again. There's nothing challenging in the patient. It can get boring doing therapy.
Uh-huh, uh-huh.
So in a way, they were also the most interesting to me because I had to figure out what's missing in the model. What do I need to come up with? What can I draw on to help patients where the cognitive therapy or behavior therapy were not enough?
Yeah.
And that's what led to developing the schema therapy, really, over a period of time.
Well, I think people who know a little bit more about schema therapy know that, of course, you're influenced by Bowlby and attachment
Right.
theory. There is a particular group of authors that I personally love that is not,
Yes.
I think, is not so much talked about these days, and I wonder if you could say a little bit about their influence, which was Guidano and
Right.
Gotti.
Yeah. And I think I mentioned it in that book too.
Mm-hmm.
They were a major influence, although I'd never seen them do therapy. So the problem was I'd like it to also be, I guess, it's another example of an abstract theory that I liked because it went deeper. But on the other hand, it was so abstract
You
that
didn't
you
know
couldn't
how
see
it was in practice.
how would you use it.
Yeah.
So as a theory, it was extremely helpful as a transition from cognitive therapy into what I would eventually call schema therapy. I would say Godano and Liotti's work and attachment theory were both extremely important influences.
And, of course, I have to touch on this, your own Gestalt therapy.
Right, and that came a little later, which is when I started Gestalt therapy. And if you talk about something again that changed my whole work, it was that.
Uh-huh.
And it was only, tell you the truth, although I had many sessions, 2 main sessions, because the first 2 sessions were just imagery work, in which he'd have me like picture myself as a child.
Uh-huh.
And all of a sudden, I just pictured memories of very deep issues, and that I had never, ever remembered because they're things from 5 years old and 7 years old. And yet they were, when I was doing the imagery work, the Gestalt therapist, by the way, doesn't do very much which we do much more in schema therapy, but they don't do much. They just elicit the image and don't do that much once you're in the image.
It's like the
but
surgeon cutting the wound and letting it bleed.
Exactly. But that by itself was extremely valuable because I could make a lot of the links to loneliness and to other things that I could never have done without the imagery, because it cut through my logical style and went to my feelings and my emotions in a way through memories that I could never have gotten to otherwise. And that was a major component of schema therapy, was having the emotion focus or emotionally oriented part of the therapy. And so it was very, very, the blending of the cognitive and the attachment and the emotion focus and the therapy relationship was really probably by that time, probably it's 1982, 1984, something around there,
Uh-huh.
I already, had seen a way to integrate them.
When you saw for yourself in your own therapy the importance or the impact of this more experiential work, did it shake your beliefs about the power of reason over emotion in a way?
Well, that had already been shaken, but I didn't have an alternative. So
Uh-huh.
the thing is, I knew already that logic and reason wasn't enough because I could see that no matter what approach to cognition I used, even in just inserting schemas, if I did them in a logical way, it helped, but
Mhm.
it still left something was missing.
Yeah.
So I was still not satisfied, and my own belief in rationality had already begun to lessen, but the Gestalt therapy gave me a concrete alternative or a concrete way to crystallize what's missing. So I would say that made something I was already aware wasn't enough,
Yeah.
and then gave me what the other dimension was that I was missing. So
So, did you have like-minded colleagues? Because you were touching on topics that were basically unheard of in the CBT literature.
exactly.
Was it kind of a solitary process developing the model?
Well, I'd say developing it was solitary, but what I did was after I'd put together the main pieces, and by the way, there is the reparenting thing if you want to get
Yeah,
that, because
yeah,
at some point it's a very important part of the
yeah.
model and differentiates it from most any other integrative
For
model.
sure.
But in any case, um, I would say that what happened then is I was supervising people from Beck Center when I was in private practice. So they'd come over, some of them would come over and get sessions from me as part of my arrangement with Beck Center. But then I decided I'd set up a little group and we'd meet and we'd talk over cases, but ones that might fit this alternative model. So
Uh-huh.
we were actually working together to see so I didn't just have my own cases, I would have their cases too, and they would try some of the things I'd suggest and say, well, this didn't work very well, or when I tried to do the imagery, this happened. Or
Mhm.
so some of the techniques we developed as part of this learning group,
Uh-huh.
and a lot of them went on to actually become cognitive therapists themselves
Yeah, and
and
you,
write their own books and their own novels.
yeah,
Yeah, yeah.
you introduced with this when you were doing this kind of work. You introduced what I think was one of your biggest contributions in a way, also to the CBT literature, which is just the simple idea of emotional needs.
Right.
And like this idea of emotional needs for many therapists from the CBT camp was kind of disdained sometimes.
Exactly.
Like
Yeah.
it's part of the demands of the client.
Right. Well, there were two things that the two parts of schema therapy that were most controversial.
Uh huh.
Some of the there was a tremendous backlash against the cognitive therapy community when I presented schema therapy as a book and has started lecturing about it.
Uh-huh.
Tremendous backlash. Some of them wouldn't talk to me anymore. They'd
Wow.
write me letters saying it wasn't that much different from cognitive therapy. Why did I have to give it a new name?
Uh
And in
huh.
fact, it was Dan Goleman who's a good friend who wrote Emotional Intelligence. And we were talking, and he said, why do you keep calling it cognitive focused schema
Uh,
therapy, whatever I called it at that time? And he said, this is different. It's not just cognitive therapy with a little bit of difference. It's a different therapy.
yeah.
Just give it another name. And I said, but I know people are going to react badly to it.
Yeah.
And he said, no, you have, it's correct. You need to do it because it's otherwise maybe politically it could be good, but it's not accurate, and it's not presenting your model where it should be, which is a different model.
Sure.
So as soon as I did that and dropped cognitive from the name, and then started lecturing about it, I got terrible back because I was like, must have been an outcast for like 5 years
Which was
of
very courageous
attacks.
because you were quite a personality in cognitive camp.
Exactly. Well,
Yeah.
that's what was happening. Is it was particularly obvious at what's now ABCT. It was then AABT, the
Yeah.
Association
Yeah.
for Behavior Therapists, and it was obvious because originally I'd been one of the main lecturers all the time on cognitive therapy each year at their conference. But then all of a sudden, I didn't want to lecture anymore on cognitive therapy because I was not doing schema therapy. And what went on during that period was amazing, because for a while, they wouldn't ask me to lecture at all.
Yeah.
Then they'd ask me to lecture, and you have a split in the feedback. Half the people would hate it because they said, this isn't cognitive therapy.
Yeah.
Half of them would love it and say, well, this isn't, this is new. This is something interesting. So they didn't know what to do with it. So it was created a problem for me both in the CBD community, but also specifically within that organization.
And did you talk to
So,
Beck about it? Do you know his feedback on that?
well, I got his feedback through other people who were friends of mine who told them what to tell me. So I got feedback indirectly.
Okay.
But I knew that his basic feeling was that, I mean, like many psychotherapists, I think they're competitive, and the idea of something that's a different model they see as, I don't know, like competition for their model.
Yeah.
And I think that rather than just saying this is great to have something new, which is how I am. When I hear a new model, I'm excited about it, even if it's not mine. I just like a new model. So, but I've learned that most people who develop models, they actually don't like new models.
Might
they
feel
like,
a little bit threatened, or
right? Yeah, exactly. And I think that's what was happening. All the CBT people were feeling threatened by a new model.
Yeah.
But I think over 10 years' time, that changed, and they started incorporating major aspects of schema therapy into cognitive therapy. But one other thing is that, which was answering your question more directly, the two biggest things they were uncomfortable with, much of it they would just say it's just the same as cognitive therapy, which it wasn't, because schemas are not the same as cognitive therapy. But the bigger thing was that they didn't like reparenting, limited reparenting, and they didn't like needs.
Yeah.
Because why do you have to insert something you can't observe, that's not empirically observable? Why do you have to insert it into your model? What does it get you? And of course, if you don't deal with personality and you're only dealing with relieving Axis 1 symptoms, you often don't need to get into needs or reparenting. But as soon as you get like severe patients, like borderlines, or people with severe personality disorders, if you don't have the idea of needs, you don't understand why they're so damaged and what they need to get better. They don't just need a correction in their thinking or in their emotions. They need experiences in life that meet those needs. And one of the ways to do it is through the limited reparenting. But if you don't accept the needs, you can't accept the reparenting, because they're linked together. So I actually think, as a contributions to therapy, it was the introduction of needs and the use of reparenting, in addition to just the putting it together in this particular way, just the way the model is cohesive. I think those are the major contributions of schema therapy.
For people who don't know, could you just briefly mention what it is, this reparenting?
Yeah, we'd call it limited reparenting, because it's important, because there were models that were called reparenting before that, where the therapist literally tried to become like the parent, and the patient would call them daddy or things like that. And then there was a big case with a Harvard professor who was doing that, and her patient committed suicide.
Oh God, okay.
And it was a terrible thing. But at any rate, so limited reparenting is basically the idea that the therapist, through getting history and doing imagery exercises, figures out which of the core needs of the patient when they were a child were not met, like the need to be listened to, the need to be nurtured, the need to have limits set. There are many that we have like 18 needs like this. And the thing is that the idea is that the therapist often can meet those needs to a limited degree within the therapy session.
Sure.
And begin to change the schemas directly by meeting the needs in the session. So if you know what needs weren't met, you meet them during the session. And we have ways that you can do reparenting for different needs. You require a different kind of interaction with the patient to meet that need.
I can imagine you training in yourself when the model wasn't developed, and your kind of solitary process trying to figure out the different needs and kind of reparenting needed for that.
Exactly. That's where borderline patients with BPD were so helpful, because they have almost every need. Almost every need they had as a child was unmet. So if I wanted a group that there was a group of patients where just focusing on these patients, I could see almost every need
You learned the
that
entire
had
menu.
right. You got the whole menu, and you can try out you can find out what things are you not doing, because when you try to do this and then they get angry at you,
Yeah.
you realize, oh well, I frustrated something they wanted.
Yeah.
What was it? Then I'll find out why were you upset with me, and then I can say, oh, that's another need I didn't
Yeah.
realize. So I have to now figure out a way to meet that need
Yeah.
too. So I'd say the BPD patients were extremely helpful in continuing to develop the reparenting idea
Uh,
and the needs.
Yeah, linking what you're just saying with something a little bit earlier on, going back to the Axis 1, Axis 2 thing.
Yeah, yeah, yes.
So, when you read Beck's classics, like Cognitive Therapy for Depression or Anxiety
Okay.
Disorders and Phobias, do you still basically agree with the major notions there, or do you now just feel that something is missing, like this more
Yeah,
characterological work?
yeah,
Yeah,
that's what I feel. There's something missing. It's an if you want to look at it, it's a good complete model of the cognitive functioning.
yeah,
But cognitive is only one component of understanding people,
uh-huh.
and it's only the one component of changing of healing all psychiatric disorders.
Yeah,
So to the extent that you only want to look at the cognitive dimension, it's a very good therapy.
uh-huh.
But if you want to look at characterological dimensions, other dimensions, emotional dimensions, attachment dimensions, the model is missing all of those things. So
Yeah,
it's an incomplete model if you try to look at the whole range of problems that come up for patients with come in with psychiatric
yeah,
problems. So, but for the patients who only need cognitive work, and that's where most of their problem is,
yeah,
and you want, and particularly if you're interested in shorter term change,
sure.
meaning just symptomatic change,
Yeah,
as I say. I think it's still a good model, but as a theoretical model,
yeah,
it's leaving out, and I think many dimensions. And of course, the more and more work there is in neuroscience, the more evidence there is that there are major parts of the brain and information processing, emotional
yeah,
processing, that are just not in that model.
yeah,
And I think a lot of that, although a lot of it's already in schema therapy, but there's no model of the brain that explains it.
yeah.
And I feel a lot of the neuroscience is very helpful in sort of validating some of the constructs, because a lot of them do come up when they do, like there's a field now called affective
Yeah,
neuroscience,
yeah. Mm-hmm.
which is very interesting. And in that field, you have a real specific focus on the emotional components
Yeah,
of the brain. And those are the ones that I feel are not adequately dealt with in cognitive
yeah,
therapy.
yeah, yeah,
But I still think it's still good for if you can focus just at the cognitive level.
yeah, yeah.
I think all the books on cognitive therapy are still good.
Mm-hmm. And I remember what I felt more frustrated with. I liked I enjoyed always reading the books. I always felt the lack of the developmental issue of how did we get
Right.
here. Yeah.
Right. And that's of course where the needs came in, because you see, in order to have, because I was very interested in origins, but I didn't like the way psychoanalysis looks at origins. And there was no model. I looked at many models for childhood development and origins, and none of them seemed to really be complete enough or they weren't really the kinds of origins that were the things my patients had experienced that gave them their issues. So I had to develop origins to go with each schema.
Yeah.
But as I started to figure out, well, what are the origins of the schema, I would start getting back inevitably to a need that wasn't met.
Mm-hmm.
So let's say I get back to the origin of somebody who was, let's say, someone who could never get intimate with anybody.
Mm-hmm.
I find that many of them would have extremely cold, distant, unaffectionate parents.
Yeah.
And then I'd say, well, what effect did that have on the child? Well, then I said, well, there must be a need the child has to be nurtured, to be someone to connect with them, attached to them. And that if that need wasn't met, then the patient develops a schema.
Mm-hmm.
Then the schema leads to various symptoms in many cases, or life problems.
Yeah.
So the needs and the developmental thing for me ended up being the same exploring developmental origins and led me into needs. And
Yeah.
that's so to me, if you don't understand the developmental origins of a patient's issues, you don't understand the patient. You haven't
Yeah.
conceptualized it, and you will not be able to help them enough.
Uh-huh. Uh-huh.
So to me, it's like essential part of doing psychotherapy is to really and in a very specific way know what the development or mental origins were. Not just they had a distant parent or there was abuse. It can't be general. It has to be specific to the patient. What did the parent do or not do,
Yeah.
and what need did that frustrate in the patient?
Another thing I really enjoy about the model is sometimes giving importance to the schemas of the therapists themselves.
Right. Right.
I like to kind of like I wouldn't say challenge you, but still a little bit of
Sure.
disclosure question in the sense that what are some of the schemas you might have had that you had to work on in order to do better therapy?
Sure. Well, I'd say that one obvious one was, well, one of them I'd say was an advantage in doing cognitive therapy because I could relate to it in patients. But I'd say one of my main schemas is emotional deprivation, which is the idea of not getting enough enough affection, warmth,
Mm-hmm.
listening, and empathy. And having had that as a schema and that as a childhood origin, it wasn't an obstacle to doing therapy, but in the opposite, it actually allowed me to understand it better.
Okay, yeah.
And you see, so sometimes having some schemas
Actually help.
actually help you. But many schemas help because when you have someone with that issue,
Yeah.
if you've worked on it. Now,
Yeah.
so the problem becomes not do you have the schema, it's have you ever resolved it and are you aware of it?
Yeah.
And if you have a therapist who has the schema,
Yeah.
doesn't know they have it and hasn't worked on it,
Yeah.
then they will not be able to meet the need of the patient, the
Yeah.
core need of the patient, because they don't realize they didn't get it. So let's say before I was aware of that, if I'd had a patient, I had a deprivation, but I had a patient who also wasn't nurtured, I wouldn't understand what
Yeah.
it was they needed because I never got it myself.
Yeah.
So how could I then give it to the patient?
Yeah.
So that would be an example of
It's a
an
great
issue.
example.
Yeah. And I'd say but since by developing the model, I had to work on the schema. So in a way, when you develop a model, it's not that often you encounter a schema that you have that you're not aware of. And if I did, then I'd add a new schema because I knew there was something I wasn't getting. So I'd say the biggest thing is really the therapist's understanding of their own needs and childhoods and schemas, and having done enough work to correct it that they can then meet the needs of their patients. And at this point, I guess if I had to pick one that maybe a need that maybe wasn't met enough that's still creating problems with patients, I would say it's probably not a schema. It's a temperament thing. Like I have a slightly impatient temperament. Like I like to go fast, and I have to learn to be patient. I've learned over a long time to do it. But I think that's we do have a temperament as part of our model, and some things are really not your schemas. They're your nature, your temperament.
Still working on it.
Yeah. So I think, and that I'm still working on. But I would say the schemas I've mostly worked on, but most of the people we've coming in, of course, when they're starting, don't know their own schemas, certainly have not gotten therapy or training to work on that schema. And therefore, there's almost always something, and I always say borderline patients trigger almost every schema. So whichever one you're not aware of, they will trigger. And then we find out what schema the therapist is not aware of and how to deal with it. So
they're
but it's essential.
friends.
Exactly. So it's an essential part of the model that the therapists know their own schemas and see how they're playing themselves out in the therapy session with particular patients, and then do enough work on themselves to be able to at least be able to meet that need for the patient. Even if they can't completely heal themselves, at least they need to be able to recognize it when they see a patient and not let their own issues get in the way of providing good therapy.
So Jeff, we're drawing here to a close, but also bringing up lots of things that you've been talking about. If you were in therapy yourself now, how would you describe your ideal psychotherapist?
Um, well, of course, it's a little different now because now that I have a model to understand myself that I
Uh,
use. But
you need a schema therapist now.
yeah, what if maybe it'd be better to go back to if I hadn't developed a therapy and I was
Sure,
looking
yeah.
back and said when before developing schema therapy, if I were looking, what would I look for in a therapist with given what I now know?
Yeah.
I guess I would say I'd look for a therapist who could meet my own unmet needs. So I need someone warm, not just, I call it the role of the therapist. Some people play the role of a therapist. They know how to pretend to be warm or pretend to listen.
Yeah.
It needs to be someone who's very genuine, very direct, someone who will truly care, someone who's loving, if possible. So I'd say for me, that element of the personality is probably the most important single thing. Second, I think, is someone who's able to see patterns. And I always say in what I've learned in schema therapy is it's your ability to spot patterns, because when a patient comes in, they don't tell you, well, here's my schema. What they do is they give you lots of examples of things in their life, and you can get examples from their childhood, and you have to put them together into a pattern. And if the therapist can't see your pattern, they can't get you to change it. So I think the ability to spot long-term emotionally based patterns would be an absolute necessity in a therapist working with me.
Uh-huh.
And then I'd say I'd want somebody who could understand origins enough to help me at
Make
that
that connection.
make a connection. See, why do I have this pattern?
Uh-huh.
Why am I having trouble with this? So I could make a link that makes sense to me.
Yeah.
And then they have to have enough life experience and judgment to know what would help me solve it. Because it's separate. You can understand it. You can be warm, but you've also got to figure out a way to get the patient and help the patient find solutions. And often those are relationship behave, how you are in relationships, how you overreact or underreact to situations. And so you need a therapist who's able to get down to really specific things in how I interact with people or work or whatever, and help me to make those changes.
Seems like an
And
active
that's
therapist also.
right. They have to be active,
Yeah.
exactly, but not primarily skills oriented. I need to feel understood and cared for.
Uh-huh.
And once I feel that, I need guidance to help me say, well, like here's a therapist who would say, well, look, when I was in a relationship, X relationship, when I was younger, I did so and so, and it had this effect. Then I learned that if I did this instead, or if I could say this instead of just keeping it to myself, they'd feel more loved.
Yeah.
So I think you need to find a way to express what you feel but don't say, and express it to the person so they know what you feel toward them.
Yeah.
So let's practice that. Let's pretend I'm your, partner or whatever, and now let's play. How could you express your feeling to them? So they'd make it concrete. They'd be telling me what to do, and they'd be able to help me to do it.
So, and having said that, how optimistic are you nowadays about deep schema change? Have you actually seen this happen a good number of times along the way?
Yes. Oh, yeah. If I hadn't seen deep schema change, I
You wouldn't be doing it.
wouldn't be doing it. Yeah, exactly. So I would say that I see deep schema change all the time. I don't mean every patient, but I mean I see it all the time, meaning there's always a significant percentage of patients that I see who make deep schema change. However, I've learned that deep schema change is not usually getting rid of the schema, and it's not usually being 100% healthy. It's making significant schema change, and in particular, enough schema change that it allows you to deal with the world differently. So sometimes you can deal with the world differently, get your core needs met, and develop good relationships without completely healing every schema you have. But at least when
It's
the schema it's adaptive. But also if it's still there and it gets triggered by something, let's say a boss says or someone says, I overreact, I can figure out that I overreacted and why I overreacted, and then tone it down.
Yeah.
So I can't always stop the initial emotional trigger,
Uh-huh.
but I can change what I then do with that once I know the schema. So in
Yeah.
some cases, my actual reactivity, if you really change the schema, your reactivity to the situation goes way down,
Yeah.
or isn't there anymore.
And you've seen
But
that. Yeah.
right,
Uh-huh.
I say
Yeah.
I've seen that a lot of the time.
Uh-huh.
But more frequently, you get someone where the reaction to the same situations they used to is very much lower, very manageable, and they understand it.
Yeah.
And then their life can be happy. And that is the goal. The goal is not to get rid of every schema. It's to be able to weaken each schema that's important enough that the patient can have a happy life, fulfilling life, healthy relationships.
Yeah.
That's really the goal.
Jeff.
But if there is not significant schema change in most patients with long-term problems, the patient's not going to get better.
Uh-huh.
That's right.
One last question that I still like to
Sure.
ask you. I've asked all of our colleagues is,
Sure.
what advice would you wish to have received when you were starting out as a psychotherapist?
I would have liked to have someone who already had a model so that I would have known what I was looking for. So I don't know that there was advice. I already knew how important the therapy relationship was, because when I'd go to look for a therapist, I knew I was looking for someone of a certain personality type.
Yeah.
I wasn't looking for any skills. So that I already knew. I guess if someone had said to me directly, you don't understand emotion enough, and because of the way you were brought up, you haven't incorporated emotion either into your own development
Uh-huh.
or into your therapy.
Yeah.
And therapy is not just about logic, it's also about feelings, relationships, and closeness. And you need to find a therapy or develop a therapy that allows you to balance your logical side, which you already have, with a more emotional and, I'd say, attachment-oriented side. That would be something I think someone could plausibly have said to me back then that was known, that would have helped.
Yeah.
And they would have had to say it very forcefully, because I would have argued about them logically and said, why would you need it? But I could have been convinced through many examples
Uh-huh.
if they had pushed hard
You
enough.
could be
But
logically convinced.
right, exactly. That's right. I could be logically convinced enough to go and get help from someone who did that kind of therapy at an earlier point in my life than waiting until I was in my 30s to do it.
Jeff, this is a great opportunity to talk. Thank you so much.
Great. Well, it was great. I'm glad to have an opportunity to share all of the different experiences I've had, because I think, and if it helps other therapists, that's wonderful.
I'm sure it
And
will.
also, I'd say to therapists, one more thing
Of course.
is always think of yourself as someone who potentially could develop a therapy or significantly add to approaches to therapy. Don't look at yourself as someone who just learns therapies. Always look at yourself as someone in saying, what can I contribute to therapy? How can I advance therapy, either the theory or the technique, in a way that would both help me and patients, but also that I could teach to other people? I think many therapists, either their modesty or they're getting locked into a model, keeps them from thinking, maybe I could actually either develop a model or make existing models better than they are.
That's spoken like a true integrationist.
Yeah, well, exactly. It is. And it's also a true belief that people shouldn't stay stuck in any model or combinations of models that they have. They should it's not just finding other models. It's you trying to figure out things that are missing and you trying to find solutions, either partly by yourself. You don't always have to look to other people to find them. Sometimes you can find the answers inside you if you'll experiment and try things and be experimental.
Thanks so much, Jeff.
Okay, good talking. I'm glad we had a chance to talk, Alexander.